back, everyone. Let's now move on to the panel keynotes and discussions. To chair this session, I would like to welcome Professor Monica Lakhanpaul, University College London, UK. She's a professor of Integrated Community Child Health, Population Policy and Practice Department, UCL GOS Institute of Child Health. She's also the co-investigator of our project. Welcome, Professor Monica. It's over to you now.
Thank you very much. It's a great honour to be here to chair this last session of the day. I hope you've all had a wonderful meeting over this week and last week, and we have such eminent speakers to share their knowledge with you in this last session. What I'll be doing is I'll be introducing each speaker with some of their bios, but they have extensive bios, so I will only introduce them shortly, and then if you could read their bios in much more detail, that way we can have more time for the question and answer. You'll also see on your screen that you have a chat button where you can chat to each other, make networks, link with each other, and also a Q&A button. So please do ask your questions in the Q&A chat so that we can then pick up some of the questions for the panel discussion later on. And we can also respond to you if we don't have time either. So not waiting any longer, we're going to be talking about mental health literacy, public health, policy, a wide array of different talks you're going to hear about today. We've got about 5 speakers, and I'll take each one in turn and introduce them in turn and then welcome them to the stage. So moving on, I'd like to just invite our first speaker. Our first speaker is Dr. Tasneem Raja. Dr. Tasneem Raja holds a role as a lead for mental health at TATA Trust. She has led the development and implementation of innovative and scaled programs spanning the continuum of mental health care in the district of Nagpur in Maharashtra. She's currently a PhD scholar at the Warwick Medical School, University of Warwick, very close to my home, and she's also leading on a randomized clinical trial evaluating the effectiveness of psychiatric hospital reform in India. She holds a number of different degrees, we're just honored to have her here. She's led large-scale implementation programs on the ground across India, so has a very wide knowledge of India and the context in which we work. She has other awards as well against her name. She currently serves as a member of the State Mental Health Authority in Maharashtra, governing board member for the Spastic Society for Karnataka, and a trustee as well on the Suman Foundation, and member on the research committee for the Kripa Foundation. Amazingly, she's also been awarded the Exemplary Woman Award and the Sector of Social Work by Zee Television in association with the Archana Trust Suburban in 2005 for her work in community empowerment and HIV and AIDS. I'd like to welcome Dr. Raja to the stage. Thank you.
Thank you, Dr. Lakhanpaul, for that introduction.
Thank you. We'll go on to invite our other members now to the stage as well. So our next speaker is Professor Srinath Reddy. And Professor Srinath Reddy, I'm sure, does not need an introduction by any of us. He's well known across the country and really been pioneering a lot of the work around COVID over the last year. Professor Reddy, as we know, is the president of Public Health Foundation of India. He's led the development of PHFI, which has established 5 Indian institutes of public health in different regions of India. And he's advanced multidisciplinary public health education, research, health technology, and implementation. He was appointed as the first Bernard Lown Visiting Professor of Cardiovascular Health at the Harvard School of Public Health between 2009 and 2013, and presently serves as an adjunct professor of epidemiology at Harvard as well. He's also a Padma Bhushan awardee in 2005 and holds advisory positions in several national and international bodies, and has also written books as well that I'm sure many of you have read. He's an adjunct professor in Sydney as well, and also he's the first Indian to be elected to the National Academy of Medicine in the USA, and was awarded several prestigious international and national doctorates and fellowships. Professor Reddy is a member of the government of the Indian Technical Task Force for COVID-19, so we thank you very much for that, and advisor to the governments of Odisha, Andhra Pradesh, Haryana, Punjab on public health, and president of the World Heart Federation between 2013 and 15. And he's also co-chair of the Health Thematic Group on the UN Sustainable Development Solutions Network. I'm sure there's many, many more things we could say, but thank you very much for coming to the stage, Professor Reddy. So just moving on to our next speaker after Professor Reddy will be Dr. Abhijit Nadkani. Sorry for that, Nadkarni. Dr. Nadkarni is co-director of the Addictions Research Group at Sangat. Dr. Nadkarni is based at Sangat's headquarters, and this is in Goa. He's an associate professor of global mental health at the London School of Hygiene and Tropical Medicine in the UK. His research interests encompass global mental health, and particularly the development and testing of contextually appropriate complex interventions for a range of mental health and substance use disorders. A lot of his work is based in the Sangat, where he started, and he leads the Addictions Research Group there. He's also actively involved in capacity building of mental health researchers, which is so important for the future of mental health services and research, and lays health workers, and also he leads a program for lay health workers across the world. This also includes his role as the course director of Sangat's annual short course on leadership in mental health. Thank you so much again for joining us today, and we look forward to your talk as well.
Thanks, Monica.
Thank you. And moving on swiftly now, we move to Dr. Pratimak Murthy. Dr. Pratimak Murthy is Professor and Head of Department of Psychiatry at NIMHANS and took charge as full-term Director of the Institute on the 18th of June 2021. Dr. Pratima brings about 30 years of extensive experience and exceptional accomplishments in the field of mental health. Dr. Murthy is a well-recognized leader in addiction psychiatry, has been instrumental in the successful development of state-of-the-art Center for Addiction Medicine at NIMHANS. I was lucky enough to visit NIMHANS as well before the COVID, so I remember it fondly. She's also served as a consultant to prominent international agencies, such as United Nations Office on Drugs and Crime, the International Labour Organization, and the WHO. She has also served as a resource person for various flagship training programs in substance abuse prevention and tobacco cessation in the country and across the globe. Dr. Pratima is also recognised for her contribution in improving care for persons with mental health through her work with the National Human Rights Commissioner. And in recognition of her work, she has received numerous awards and honours, including the prestigious Dr. Raja Ramana State Award by the Government of Karnataka and Lifetime Achievement Award from the Rotary. And she also was honoured with the WHO Regional Directors Specialist Recognition Award on World Tobacco Day 2021. So many things to say there. You can see we've got such an amazing panel of speakers. So thank you very much for joining us, Dr. Murthy.
Thank you, Professor Monica.
Wonderful. And not last, but not least, for our last speaker, who is Manoj Chandran, who I have met very fondly when I was visiting India. Manoj and I had a wonderful conversation about mental health and the way forward for research. Dr. Chandran is the founding CEO of White Swan Foundation for Mental Health, a non-profit organization with the mission to deliver knowledge services on mental health and well-being. Founded in 2014, White Swan Foundation has developed India's largest knowledge repository on mental health for the public, and we can send you the link to his foundation. White Swan Foundation runs several community outreach and mass communication programs to educate people on mental health and well-being. And our friend Manoj has more than 28 years of experience in a wide range of areas that include journalism, communications, marketing, strategy, and leadership. So welcome to the stage as well.
Thank you, Professor.
Thank you. So thank you all for joining us today. And so if it's possible, we'll just start with the first talk, and the first talk will be given by Dr. Raja. Thank you. Over to you, Dr. Raja.
Thank you, Dr. Lakhanpaul. And I'm just going to share my screen. How's this?
Can we help you? You okay?
It's just frozen. Can you hear me?
We can hear you fine.
Oh, okay. So it's just frozen. I don't know if someone can display the slide deck from behind. I'm just going to continue talking. And so, okay, shall I just go ahead and talk, Dr. Lakhanpaul, because I mean, the slides are just a support tool.
Yes, please go ahead, and we'll see if somebody behind can put some slides up for you.
Okay, thank you. So thank you for inviting me as a speaker on this panel. It's an honor. So thank you for that. I'm going to be talking about the program that we run in the district of Nagpur. The program has two large components, one of which is the reform of one of the 47 psychiatric hospitals in this country, all of it, most of which were established during the colonial rule and carry vestiges of that era with them even today. And the second component of that, which is really the focus of my talk today, is the building of a model district mental health program. Both these pieces of work are by the Tata Trust in collaboration with the government of Maharashtra. So the district mental health program covers the entire district of Nagpur with a stated population of 4.6 million for the census 2011. It has about 800 revenue villages across. It has 13 blocks, 800 revenue villages, and this does not include the city of Nagpur. And it has 49 primary healthcare centers. It has 9 rural hospitals or community healthcare centers and 2 sub-district hospitals. Interestingly, it does not have a district hospital, but it has medical colleges. So I have control of my slides, and that's nice. Okay, so the district mental health program, which is the community mental health program.
Sorry, Dr. Roger, are you sharing your slides with us? Okay, I think we'll let Dr. Roger come back and give her talk afterwards. Professor Reddy, would you mind taking the stage and speaking first? Is that okay?
Sure. You want me to go now?
Yes, please. Thank you.
Okay, sure. Well, it's very clear. Thank you very much for this invitation. When we are really talking about mental health issues and trying to pose it in the context of the agenda that we have to set for public health, we must recognize that firstly, we have a very cross-cutting area to deal with, which involves multiple disciplines and not necessarily something that is confined only to psychiatry or psychology. We know that many of the mental health conditions overlap with other health disorders or even risk factors. We know that much of mental health challenges, particularly depression, are reactive in nature to physical illness or unfavorable circumstances, which can be tackled. And these external conditions are among the various determinants that public health deals with in terms of trying to alter them to favor health. And therefore, when we really look at public health's agenda, it is to address a very wide spectrum of mental health disorders and their determinants. And we recognize these as elements of mental health afflictions which accompany chronic illness, sometimes may occur in the context of pregnancy, peripartum, postpartum, or we have seen in COVID itself a number of conditions arising, whether we call it brain fog or many other areas of mental health disturbances, particularly of depression following the illness. We have seen road rage, we have seen addictions, we have seen domestic violence, we have seen gun violence. All of these are phases of mental health disturbances which very much fall within the broader ambit of public health. Even the addiction to the internet or social media is an increasing mental health challenge of late. particularly where we see a large number of people who are especially young, unfortunately, who are digitally hyperconnected but empathetically disconnected. And therefore, these are kind of challenges that we must certainly deal with. But when we raise such a broad canvas, the initial question that will be posed is public health supposed to address all this? Is it capable of addressing all this? What indeed is the domain of public health if mental health is an individual affliction that falls essentially within the domain of clinical competence? So where does public health come into the picture? Well, public health is a confluence of disciplines which together identifies and influences the determinants of health so as to impact upon and improve the health of individuals. It deals with the population and the factors that are at the population level so that individuals are ultimately protected. Whereas clinical medicine very rightly deals with individuals and provides health in retail, public health protects and promotes health in wholesale. And therefore, it's at the level of the population that it does operate. And we must recognize that by doing so, it is capable of altering the dynamics of society, dynamics of a population group, ultimately to improve the health of individuals. And we therefore recognize that there are multiple risk factors which operate, which influence population groups and the individuals therein. And these risk factors precipitate or perpetuate a pathology. But further upstream are the determinants, which are economic, social, cultural, commercial, and environmental, which drive these various risk factors and can tilt the balance between health and disease. And therefore, it is absolutely imperative that we try and influence several of these determinants and see how best we can alter them. Whether it is global warming or air pollution or road rage, these are all societal factors which disturb the mental balance and tranquility of individuals and groups of people and ultimately add up to a cumulative burden of rising mental health disorders. And these are all eminently amenable to social interventions through public health measures. And public health does that through a variety of instruments and approaches, through policies, through programs and services, through systems, by configuring systems, and by engaging the community. And that is where we must position our interventions in terms of ensuring that mental health is fostered in order to provide the broadest spectrum of protection to mental health, even as clinical medicine steps in to try and provide reparative support to people who have already had a mental health affliction as a result of multiple risk factors. So therefore, we are dealing with a broad band of health promotion, prevention, diagnosis, treatment, rehabilitation, and palliation. While these may be focused to some extent on individuals and may be delivered by individual clinicians, some of them, especially the diagnostic, treatment, and rehabilitation part of it, or palliation part of it, the fact that the teams are assembled who have the requisite competencies and are positioned in settings where they can deliver these services is a matter of health system planning and configuration, which comes under the broader ambit of public health. And therefore, public health has to see, right from prevention to palliation, how best mental health can be protected, promoted, preserved, and restored. And as we have moved over the decades from looking at the management of mental health disorders as an institutional responsibility of incarcerated patients to community-based approaches for protecting and tending to mental health afflictions, we see public health mandate becoming broader and larger. And therefore, we are acting right from determinants to actually setting up systems where individuals can be provided better care. And here, primary care settings become absolutely pivotal. And we are talking in the context of primary care-led universal health coverage, where I believe primary care is a very principal agent of providing better mental health services to the community. So we have multiple settings in which this can operate. Community is, of course, the largest, but we also have other settings like workplaces, schools and colleges, women's groups, youth groups, elderly homes. Now, all of these places require the health system or participants in the health system to engage with the relevant community groups in order to provide the kind of supportive services and promotive services that are required. And there, NGOs and other community groups become very important partners, certainly. Early detection is going to be very important of risk factors, and timely counseling becomes very important as well. And therefore, mental health promotion, prevention, and early detection of risk factors are eminently possible in primary healthcare settings, and therefore, public health has a great role to play. It also has a role to play in those settings in order to counter stigma, apathy, and also provide support to families. Frequently in the discussion, we only focus on the individual who is afflicted, but forget that the families also require a lot of support, particularly emotional support. And therefore, the primary healthcare teams and their partners can play a great role. We also recognize that even now, while primary healthcare is going to be promoted, if we do require additional specialist advice and support, telehealth services are coming in a fairly big way, and teleconsultations are, which were now promoted during the COVID phase, can fill in the breach. But certainly we cannot only depend entirely on distant advice. We do need the emotional rapport of the primary healthcare teams to continue their support. And in different settings like community or colleges or schools, we need peer support. So training peer support groups is also an important function of the health system and of people who are interested in promoting and protecting public health. And we are also recognizing that we don't have the required number of trained mental health professionals available in most countries. And therefore, training of counselors is going to be very important, and training of even lay people as mental health counselors, particularly those in the primary healthcare teams, is very important. We have the example of Pakistan, where lady health visitors trained in mental health, essentially offering very minimal services of support, emotional support, greatly reduced postpartum depression, because where their primary function was to support the antenatal and natal care. So we know that there are a number of other examples where trained laypersons can act very well as essential support systems and deliver care in the community to people who need it. And of course, peer support groups in colleges and schools are going to be absolutely critical. But we also know that public health has other instruments of intervention. It has public health law, and public health law is a very important element for protecting rights and ensuring that the rights of mental health, people with mental health afflictions are promoted rather than eroded. And that is where I believe it's absolutely important that we position mental health also as a predominantly a rights issue. Even not just a question of how they are treated and ensuring that they're not discriminated, but even things like issues like employment, inheritance, all of these require a certain degree of legal protection. One doesn't have to go to the case of Britney Spears to talk about how inheritance is affected because of alleged mental health disorders. There are a number of other areas that we see where ordinary people are deprived of their property and their livelihoods because they're labeled as people as being mentally incompetent to look after their own affairs. So therefore, the whole idea of positioning it in the rights framework becomes very important. And there, public health law is absolutely critical. So I believe that as we address the various mental health challenges in society, which exist in multiple forms and which are actually increasing as we face more and more challenges, which are actually altering the determinants of health in a very unsavory manner. And as I said, climate change, for example, there is clear evidence that global warming increases intra-group violence and even more so intergroup violence. So we are going to see much more of this. People are going to be fighting over water. People are going to be fighting over food security. So we are going to be seeing a society which is riven with mental health afflictions. We have to deal with those determinants. But while we are dealing with those, we have to tend to those people who are threatened currently with adverse circumstances which may unmask mental health issues or already are suffering from them. Therefore, we have to set up systems for early detection and care. And here, public health has a tremendous opportunity to provide a broadband approach to mental health rather than looking at it only as a patient who needs to be put in a straitjacket. Thank you very much.
Thank you so much for that, Professor Reddy, and for talking about the context of public health and how public health needs to really support the mental health agenda and its important position in this journey. So I thank you very much for presenting that, and it's great to open this panel of discussions with your talk. Thank you very much. So we'll move on to Dr. Nadkarni, if that's okay. If that's okay with you, Dr. Nadkarni. So you'll be talking about a topic of you don't know what you don't know, barriers to accessing mental health care. So the floor is yours. Thank you very much.
Thanks, Monica. Give me a moment while I share my slides. I hope I don't have the same technical issue that Tasneem had a short while ago. And here we go. Can you see my screen?
We can, thank you. We just need to see on slideshow, I think.
Yeah.
Okay. Great, perfect.
Okay, so I guess I have 10 minutes to go through what is a pretty complex phenomenon within public health and healthcare, and not just mental health care. And I'll try my best to do this through a whistle-stop tour of mental health literacy and how the lack of it leads to a major barrier to accessing mental health care, especially in low-resource settings such as India. And why do we need to speak about this? We need to take a step back and try to understand why are we even having this conversation around mental health literacy. I think most of us who are on this panel, as well as the audience, I'm sure, know that the burden of mental disorders is increasing year on year. And if you look at the past 25 years, we know that that burden has gone up by nearly 50%, which is a humongous increase by any means. If you look at it from a slightly different perspective, what we know now is that for every 10 years of life lost to poor health, one of those 10 years is because of mental health, which is again a significant proportion of the years of life lost. And this does not discriminate based on whether you are living in a high-income country or a low-income country or a low and middle-income country. As you can see here, there's hardly any discrimination. The burden is going up across the world, regardless of the socioeconomic status of the countries that people live in. So having established the fact that the burden is very high, the key question then becomes, can we do anything about it? And why are we not doing anything about it? And that in itself is surprising why we are not doing anything about this, because there is enough evidence and more to tell us that there are enough packages of care when it comes to interventions for mental health conditions. So there are biological interventions, there are psychological interventions, there are social interventions, all of which can be used in one or more combinations to effectively reduce the burden of mental disorders. And more importantly, it's not going to be very expensive to do that. So, for example, as one of the key messages from the disease control priorities exercise, we know that if we were to scale up these packages, evidence-based packages in low-income or low-middle-income countries, it's not going to cost more than $3 to $4 per head of population or per capita per year, which is not very expensive by any means, considering some of the other expenditures that these countries make. So one would think that we know that the burden is high. We know that there are good and not very expensive interventions. One would expect then to be the reality to be that most people having mental health problems would have access to some kind of mental health care. But reality is far from that. What we do know now from a lot of research that has happened in various countries is that a large proportion of people with mental health problems do not have access to any kind of mental health care. We are not even talking about high quality evidence-based care. We are talking about just contact with any service which will provide you some kind of a mental health care. And then this varies based on conditions, and it also varies by countries. But broadly, if you look at this, if we're looking at alcohol use disorders, 1 out of 10 people with alcohol use disorders has access to any kind of care, or 4 out of 10 people with generalized anxiety disorder has access to any kind of mental health care, which by any means is not if we try to compare high-income countries with low and middle-income countries such as India and China, which are good exemplars because of the huge populations that these two countries have. In high-income countries, albeit with a slightly older evidence base from 2007, there's nothing to suggest that this has changed drastically. 5 out of 10 people with mental health problems would have access to any kind of care. If we look at India and China, 1 out of 10 people will have access to any kind of care. So again, an inequity between high-income countries and low-income countries and low and middle-income countries when it comes to access to any mental health care. So why is this happening? What are the barriers to access to mental health care in low and middle-income countries, and indeed other parts of the world as well? There are demand-side barriers and there are supply-side barriers. So supply-side barriers include things such as lack of services, shortage of mental health specialists and professionals who can provide the care, and then demand side barriers such as stigma and what we are specifically wanting to talk about today, awareness about mental health problems and mental health literacy. So we're going to focus on one of these big barriers, but we have to consider the fact that it's usually a combination of this range of barriers that lead to poor access to mental health care. And what do we mean by mental health literacy? Again, we need to take a step back and look at health literacy as the origins for the construct or concept of mental health literacy. And it goes beyond, health literacy goes beyond just having awareness about an illness. It includes higher level constructs as well as slightly lower level constructs such as accessing help. But we need to have if we have to have mental health literacy or health literacy, we need to have competencies to be able to obtain good health and also identify illness. So it's not just about illness, but also about good health. We have to understand where to access help, how to evaluate the various kind of information that we get from various sources, which is increasingly a challenge in the modern world with social media. We have to understand how to implement the treatments that are prescribed to us, be they psychological or biological, and at a very high level, obtaining and applying all of these skills to leveraging our social capital, but also understanding our rights related to health. So it's not just about awareness about particular illnesses, but very high level constructs as well. If we extrapolate this to mental health, then mental health literacy stands on these 4 key pillars. One is understanding, similar to health literacy, understanding how to access and maintain positive mental health. So again, this is not just about illness, but also about wellness when it comes to mental health. Understanding how mental disorders manifest and the various treatments that are available for them and how to access those. Reducing stigma related to mental disorders, and finally enhancing the help-seeking efficacy of people with mental health problems so that they are able to analyze the information that's available to them, take informed decisions, access healthcare which is appropriate for them, and continuing seeking help and getting help so that they can achieve mental well-being. And what are the interventions that help us achieve this mental health literacy? There are a range of interventions. These are some of the interventions that have been tried in various combinations, one or more of these various components that have been applied in mental health literacy complex interventions. So psychoeducation, which is information about illnesses and the treatments, increasing the ability to recognize the signs of various mental health problems, enhancing the perceived need. So it's just not enough if you allow or you make services available, but you have to enhance the perceived need to access those services. Modification of dysfunctional beliefs about treatment. So for example, a commonly held belief is that if you take antidepressants for depression, you will become dependent on it, i.e., you will never not have depression unless you are taking medications, and providing information on appropriate help-seeking sources. So the various interventions have one or more of these components in different combinations. So having now known that it's a problem, mental health literacy is a barrier to accessing mental health care, and knowing that there are interventions available for this, the $1 million, or rather say $1 billion question is, do these interventions work? Can we use them to increase access to mental health care? And we can look at the more recent Zhu et al. Systematic review, which looked at a broader range of interventions which were designed to increase help seeking, not just mental health literacy, but broadly help seeking. Within that review, they found 16 studies that very specifically evaluated interventions that were designed to enhance mental health literacy outcomes. 14 of those compared interventions, active interventions for increasing mental health literacy, with inactive control, treatment as or intervention, nothing happening as usual. And it showed that there was a small but statistically significant effect on increasing mental health literacy. 2 of the studies of the 16 which looked at active control conditions did not yield any significant effect. So what we can take home from this systematic review is that if we implement mental health literacy interventions, it can increase mental health literacy. But the question that comes from that is increased mental health literacy sufficient to increase access to mental health care? Does increased mental health literacy translate into changed behaviors when it comes to increased help seeking? And as we know, with a lot of interventions which are not just about mental health literacy, but about changing behaviors in a range of other fields, we know that increasing knowledge by itself or increasing awareness by itself does not always lead to change in behaviors. It might lead to increased knowledge, it might change attitudes, but might not translate into increased help seeking. So again, with mental health as well, the evidence is mixed. So increased mental health literacy does not always lead to increased help-seeking behaviors, and we have to do more beyond just increasing mental health literacy if we wanted to increase access to mental health care. And finally, before I finish, I just want to kind of do a little bit of crystal ball gazing and think about what we could do next in terms of mental health literacy interventions. I think what we first need to be doing is developing contextually appropriate interventions and testing those, because a lot of the mental health literacy interventions have been developed in settings which are different. Say, for example, in conditions that persist in India. And some of these interventions might not be suitable for us. So these interventions have to be contextually adapted and tested in our settings to see if they work. Secondly, the interventions have to be developmentally appropriate. We know that messaging for a 10-year-old can't be the same as messaging for a 15-year-old, which can't be the same for messaging for a 30-year-old. We need to have the interventions or the awareness building activities or components that we have, which are developmentally appropriate for them to be useful. And finally, it's not useful to just have interventions and implementing them on good faith, just believing that because we are implementing this, they are going to have a result in change. We need to have appropriate measures of evaluating those using appropriately developed, valid, reliable, and very importantly, contextually and developmentally appropriate measurement tools. So that's something that we need to be doing moving into the future. So that's all from me on mental health literacy. Thank you very much for a patient hearing.
Thank you so much for that wonderful talk. And it really does highlight the need to think about access. Why do people not access health care for mental health? And we see that even in the UK with South Asian communities, we have systems here, but people not accessing it due to many of the things that you have said. So we can talk a little bit about that in a bit. I just want to remind everybody that we do have the question and answer section. And I would really, really encourage you to put some questions there, because our panelists can answer some of those questions that you may want to ask and engage with them on. So please do put some of your questions in there. We'll talk to, I think, Dr. Raja, is it okay if we bring you in now so that we can have your talk first before we move on? Is that okay?
Oh, yes, sure. And apologies for the technical glitch.
No problem. I think it's probably on our side. So it's our apologies to you more than anything. Thank you.
Great. Thank you. Thank you. And you can just, so actually, in some ways, it's nice to be talking after Abhijit, because he's laid out the mental health literacy concept so very well. So I'm just going to jump straight into talking about the program. And again, apologies for the overlap with whatever you heard earlier. So this is part of the larger mental health engagement program that Tata Trust has. It's a collaboration with the government of Maharashtra with, can you move the slide? With two large segments of the program, one with the mental hospital in terms of its reform. And the second element, which I'm really going to cover in this talk, is the district mental health program and the interweave of mental health literacy across the district mental health program, which is really a community mental health care model. Next slide. Next slide. So this model sits across, it's essentially an effort to build a scalable model for district mental health in the state of Maharashtra. It has several different components. It sits on a population of 4.6 million. It has 13 the district of Nagpur has 13 rural blocks and comprises of peri-urban, rural and tribal populations across each of these blocks. And the mental health the community mental health program offers several opportunities to weave in the entire concept of mental health literacy. And I'm just going to talk to you about some of these. So next slide, please. So the first component of the program is screening for mental illnesses at the community level. It is a unique opportunity where program personnel go into households and engage with the household on mental health, wellness, illness, how to recognize illness in yourself, in others, in your household, or in the community at large. It's also an opportunity to leave behind information on well-being and also information on who to contact and where to contact in case you want to discuss anything about mental health, well-being, or illness. The next slide. So the second point in the program is the facility. Now, the district mental health program currently has 26 service points across the entire district of Nagpur. The idea of these service points is to integrate mental health care into general health care. And these service points have been kind of determined on the basis of access, especially to those populations that have the least access, and actually range from secondary care points such as rural hospitals or community health centers and primary healthcare centers in some blocks, and also sub-centers, especially in tribal blocks where access to the central service point at the block level might be very difficult for tribal populations with limited transport access, etc. Healthcare facilities in India tend to be very, very busy places. So short jingles talking about some aspects of mental health are continually displayed in these healthcare facilities to grab attention of people who visit them. There are also places where standard visual information on mental health, well-being, and illness is displayed using posters. It's also a place where we have topical engagement, especially like on marker days such as Dementia Day or Schizophrenia Day, talking to general community on these topics, signs and symptoms, how to recognize, what are the myths and misconceptions that are normally held about this, especially in the context of the district of Nagpur and its cultural milieu. Uh, what are the kinds of care that are available and how they could receive that care. So some messages are kind of structured in a manner that they are repeated in every form of engagement that we have with the community. Now, interestingly, the facility also serves as a place where you can engage with healthcare workers, uh, whether they are ASHA workers, whether they are the doctors or the community health workers, and it offers you various modalities of this kind of an engagement, whether it is on the monthly ASHA meeting days where you are given a slot to talk about mental health and well-being related issues or training issues continually across the year, or it is to engage with doctors on what are the kind of patients that could be helped by the mental health team. And over a period of time, we've seen that change in care providers' behaviors, where more and more uh, people with chronic illnesses are being referred to the mental health team just for emotional and psychosocial support. It's also a place where you can engage with women in the reproductive age group, say through the antenatal and the postnatal care seeking process that happens. It's normally held on particular days in particular facilities, and it gives you a very good opportunity to engage with them, talk about their concerns for their children, talk about the concerns for their own health, just give them a space to express. Next slide, please. The other important modality of community engagement is standard material that has been developed. We've taken a participatory learning and appraisal mechanism to this, which has actually been very effective in other healthcare services. And there's, for example, Lancet studies from in rural India and Jharkhand especially, where PLA-based community engagement actually showed a 30% decrease in infant mortality, and that was the modality. So we brought that to bear in mental health. We've developed a standard set of modules. The team that worked on this was a combination of content experts on mental health and communication experts who helped structure these into 1-hour sessions on the topics that are displayed here. So they range from topics such as stress and tobacco use to covering the specific disorders. The community engagement is layered on existing community platforms. They could be women's groups, such as what is called as Mahila Mandals in India. They could also be faith-based groups, such as satsang groups, or a congregation in a mosque or a church. So these platforms are identified and engaged with throughout the year, with at least one meeting happening with them, covering each of the topics that are displayed here. The topic itself is structured as an interactive 1-hour session, which delivers content, um, uh, contains material that the group can engage with in terms of a game or a song that is being written up, using folklore and media familiar to the community. The next slide. This is just a sneak view of some of the material. So it's a standard set of posters that are displayed across the district, either at healthcare facilities, at Gram Panchayat offices, on significant walls in the villages as wall paintings, used it as display material in the community engagement session, or given out as handouts to people who are interested in taking copy for themselves. So again, the illustrations for these were developed by communication experts, tested on their acceptability in settings like that of the Nagpur district. So this if anybody is interested, please write in for the protocols and the service packages. We are very happy to share the information. It is not completely available in the public domain, but we are happy to just send it across to you as a soft copy over the email. So this is the range of mental health literacy work that is being done as part of the community mental health program in Nagpur. So thank you for giving me the opportunity, panel, for having this discussion.
Thank you so much for that wonderful presentation. And it's actually very close to my heart, community interventions, because the PLA that you mentioned, the Participatory Learning and Action Cycle, is something that we have adapted for the UK context, not for mental health, but for nutrition. So we in the UK are actually learning from India on what interventions would work with our communities in the UK. So it's wonderful to hear you present this work. So thank you very much. And so moving on now, I mean, Professor Reddy did talk about the legal side of mental health. And so, Dr. Murthy, this is a wonderful time for you to talk to us about human rights and mental health policy in India. So over to you, and thank you very much.
Just give me a moment to try and share my presentation.
No problem. Meantime, please, everybody, continue to put some questions in our question and answer section.
Can you see my slides?
Not yet. We're just waiting for them to come.
Okay, can I just request the organizers to share my slides? That might just be quicker in terms of the time. I know Sanjana does have the PowerPoint. Thank you very much, Sanjana. That's the easiest thing to do. So I'm just going to take you from the micro level, the talk that Tasneem gave on literacy and the points that Abhijit raised, to look at how this kind of panned out in terms of the human rights and mental health policies in India. The next slide, please. So what I want to talk about is something that Tasneem referred to in passing, which was perhaps what happened a couple of decades ago in terms of mental hospital reform in the country, and then how we've now moved in terms of transitioning mental health policies. So we know that whenever we talk of tertiary care, we need to move from custodial to caring settings, from involuntary admissions, which characterize most of the mental hospitals in the country, to voluntary care, not just in mental hospitals, but in departments of psychiatry, in NGO settings, in community settings. We had custodial settings which were very jail-like just about 20 years ago, and possibly still continue in some of the places in the country, to more therapeutic settings. And the Nagpur Mental Hospital is an example of that transformation. We've had outdated infrastructures, so we needed to have more modern facilities in terms of care for patients. We had staff who were never trained on the job. So whether it's in the hospitals or in the community, you need to have people who are professionally trained to deliver the services. We also hope that finally, whatever mental hospitals exist in the country, in spite of all their transformation, we would like them to become centers of training and excellence. And for example, NIMHANS is such a hospital which has transformed, and so are several other hospitals like that. And of course, from inpatient care, we need to shift to community care. So there have been several such interventions. We looked at, for example, the issue of people in mental hospitals way back in 1999, and what transformation occurred when they were revisited in 2008. The National Commission of Women, they supported a study in 2015 to look at the conditions of women in mental hospitals, which actually were similar problems to women, for example, in jail, as was done by the National Commission for Women several years ago in 1995. So then subsequently, there was a report of the Technical Committee on Mental Health in 2015, and I'll talk about how this transformation actually occurred. The next slide, please. So in the NHRC report in 1999, of the 59 facilities visited, both in the government as well as in the private sector, 32 of them were state-run mental hospitals. We also visited general hospital psychiatry units, private psychiatry centers. And at that point in time, 75% of the institutions had only closed wards predominantly. They were predominantly involuntary admissions in 69%. And there were cells, having people isolated with very, very minimal facility in a large number of these hospitals. The next slide, please. So there were no specialized child psychiatry services. There were very few facilities which offered family treatment services, very few facilities which offered substance use services. Only a small number of hospitals had newer antipsychotic medication for people with severe mental illness. And again, most of them did not provide emergency services. The next slide, please. And you'll see that in terms of the changes that occurred between 1996 and 2008, emergency services improved, facilities in terms of guest houses improved, adequate outpatient facilities improved in a number of these hospitals, canteen facilities to help family members visit these hospitals also improved across the 2 time points when we revisited these mental hospitals. How did this occur? Next slide, please. So you'll see that many of the hospitals actually downsized their bed capacity because they were simply too large and too difficult to kind of manage. Although some of these hospitals have reduced their bedside, overcrowding continues to be a big problem, particularly in some of the hospitals in Maharashtra, where these kind of changes haven't occurred as successfully as in some of the others. The next slide, please. The other change that occurred were in hospitals which were monitored by the National Human Rights Commission, which actually commissioned the study. Based on the Supreme Court directives, a set of rapporteurs were nominated, and they actually worked with state governments to improve budgets to the various mental hospitals. And you will see here that in NHRC monitored hospitals, the budgeting of these hospitals increased. And with the budgeting, several of the infrastructure that occurred and things like diet, etc., training of the staff, all of it improved when these hospitals were being monitored. In the case of Nagpur, of course, TATA Trust took over the hospital and have been able to bring about a lot of changes in that hospital as well. The next slide, please. So you'll see again in the NHRC monitored hospitals that in terms of the voluntary admissions, a huge change occurred in terms of a reduction in the involuntary admissions. A lot of changes occurred in terms of the diet that were given to patients. So in summary, when you monitor these facilities and make sure that state governments invest better, they can be improved, is one learning that we had in terms of the changes between in the mid-1990s and 2008. The next slide, please. So the areas of positive change were a reduction in the court admissions, improved structural facilities, living conditions had improved, diet had improved, more hospitals focused on recreation and rehabilitation, greater collaboration with NGOs, as in the example of Nagpur, regular community level activities were initiated, and improved budgetary allocations were made. However, the staff issues, having a lot of vacant positions, particularly in the government hospitals, lack of psychosocial interventions, continuing closed wards, and lack of postgraduate training still remained as areas where poor progress had occurred. However, this report would not have come to light, say for the Erwadi tragedy which occurred, as all of you know, in the Ramanathapuram district, where then the Supreme Court took suo motu attention and brought this whole report into the public gaze. Subsequently, what happened is that many of the recommendations of this report actually took fruition, and then subsequently we also realized that care cannot be confined only to the tertiary care hospitals, but needs to be driven by the community. Remember that there was a national mental health program way back in the early 1980s. However, this had not really expanded, and the work of the NHRC allowed the gaze to shift from the tertiary care institutions to community care. Next slide, please. So what has happened beyond institutions? We've talked about the treatment gap. Abhijit mentioned it. Dr. Reddy talked about it. We also know that there is a need for decentralization of mental health care facilities. We've talked about the human resource scarcity of specialists and the need not just to have specialists, but also non-specialists to deliver basic mental health care, both medical doctors, healthcare workers, as well as lay counselors. So that's the general shift in terms of shifting the whole focus of care. A very poorly informed public, and we've talked about the need to improve mental health literacy. We have a very small NGO sector for mental health, and that needs to expand. The gender dimensions in terms of the kind of, the problems that gender itself poses in terms of mental distress, access to treatment for antenatal care, perinatal care, and so on. A lot of vulnerable groups whose mental health distress is very high, different settings, not just workplace settings, but custodial settings and so on. And we know that COVID-19 has really transformed some of the treatment gaps into actual chasms for, in terms of inadequate mental health care. So we need to look beyond institutions and attend to all these domains. The next slide, please. So what has happened in the last decade or so is the report on the Technical Committee on Mental Health, the National Mental Health Survey, which has told us that the treatment gaps are huge, that states need to look at the mental health problem and evolve interventions that are suitable to the states. We have a national mental health policy. We have a new Mental Health Care Act, which talks about right to access care, to integrate mental health care into general health care, entitlement for reimbursement if services are not available at the government level, essential drug lists to make at least psychotropic medication for severe mental illness available, and of course to improve human resources in the area of mental health care service delivery, both in the specialized as well as in general mental health care. So these have been huge advances in the last 10 years in this particular area. Next slide, please. And what are the challenges and responses that still lie ahead of us? Apart from the huge treatment gap, which we are trying to address, for example, through digital means and so on, there is a lot of resource variability across different states. And that is very, very inequitable. We also need to give adequate importance to mental health care, and sadly enough, COVID is perhaps the reason why the attention has increased to mental health care. Stigma and the convoluted help-seeking pathways is another challenge ahead of us. The need to strengthen primary as well as secondary mental health care, to make universal care and universal mental health care, which is rights-based, greater investment, of course. The range of mental health interventions from self-care, which a lot of us need to be aware of, to institutional care. We need to have a menu of supportive services. We need care in multiple settings. And we need to integrate mental health care into both communicable as well as non-communicable disease programs. Finally, I'll just end with some of the interventions that we at NIMHANS have been doing. The next slide, please. So, of course, I talked about the expansion of before that, the district mental health program expanded hugely in the last 4 or 5 years. It's now available in 655 districts, but of course at various levels of efficiency. However, it has actually got initiated only in the recent few years. The next slide, please. So in NIMHANS, we have the NIMHANS Digital Academy, which has looked at digital training. We offer a diploma in mental health. Now, there are now state-run digital academies in Gujarat. Teletraining is available in Bihar, Chhattisgarh, Karnataka, Maharashtra, and Uttarakhand. Sikkim has initiated a suicide prevention program. We've trained all the police in Tamil Nadu to actually identify mental health problems and improve mental health among their staff. Prisons in Karnataka are now taking up mental health interventions. So you're actually seeing a lot of these interventions occur. Next slide, please. So the road ahead, the Ayushman Bharat conceives health and wellness centers. There are going to be 1.5 lakh centers in the entire country with mid-level healthcare providers, comprehensive primary mental health care, and several components which include mental health interventions. So this is an opportunity to actually promote mental health as well as early identification and management of mental health care services. So I'd like to conclude by saying the road is long and convoluted ahead of us. There have been a lot of strides in terms of mental health development. However, we still have miles to go ahead of us. Thank you very much.
Thank you so much, Dr. Murthy, for that amazing talk. It lays out all the work that you're doing all the challenges ahead and all the challenges that we've actually had to deal with in the past as well. And you raised some important issues about gender and the role of gender, and also about how we need to engage with people with mental health in a human way. I mean, we're all the same in the end, and how we can actually consider how individuals are treated and how to give them some self-respect as well. And we may come back to that. So just as for our last speaker, Mr. Manoj Chandran, thank you so much for being so patient with us all. And we look forward to your wonderful talk on mental health literacy in India and affecting a systemic change. Thank you. Please go ahead.
Thank you, Professor. It was wonderful to listen to the esteemed panel before me, and I'm so glad that I get to speak about mental health literacy as we learned over the last 8 years under White Swan Foundation. In fact, when we started our journey about 8 years back, we didn't know that the term would be mental health literacy at that time. And so there are a few lessons that we have, and I'm going to look at from the perspective of the audience. And we've had wonderful insights coming in from the system perspective and the infrastructure and the need aspect of it from a care and knowledge thing. But from on the ground, when we are talking to audiences, I mean, we have had some learnings, and that has really helped us transition and build and evolve in our offerings and knowledge packaging when it comes to mental health literacy. So here are my few points. Now, when we look at mental health literacy, we have been asking exactly what is the core objective from the common man who we are talking to and engaging in discussion on. So what we understand at the fundamental level, it is about helping them make right decisions on the topic of mental health. There is a certain aspect of decision making that is already happening, and then mental health literacy has this objective and vision of trying to direct them into right decision making. And that is a difficult one. Now, looking at literacy in general, content certainly continues to be the king. And like Dr. Nadkarni pointed out, we have to make it extremely contextual, particularly when it comes to mental health. We've had that learning a lot of time when we sat down people to explain about what we would want to give them. They said that I don't connect with it, I don't understand this. And we had to really understand, go back and redraw our content every time we would talk to different audiences. So, and content, the way we created the format aspect of it, and the messaging that we will have under each of the content continues to be an important aspect of how effective, impactful mental health literacy programs could be designed. Early on, when we started our journey, we said that perhaps the most important stakeholder in mental health literacy would be those who perhaps know that they need information to make right decisions about their own mental health issues or that of their dear ones. But over a period of time, we realized that the most powerful stakeholder in the ecosystem is the bystander, perhaps. So how do we, and we need to therefore understand that every single citizen is a stakeholder of mental health healthcare ecosystem, and therefore our audiences must include the bystander also. And it has been a difficult exercise to really tell those people that I'm also talking to you. One of the reasons why this is also so important is because you know, at one level, when we are connecting with the individual and imparting mental health literacy, there is that individual information need, individuals who can play a role in their own sphere of influence. But they also need to be told about their role in the community that they are part of, whatever they could be. It could be about schools and colleges or larger community. But that whole literacy effort and mental health literacy initiatives must also include that aspect, but they are able to understand that they need to bring in about some kind of effective change in the way mental health care works, or the discussions, the communication, the attitudinal aspect that exist on mental health care. And that is how perhaps, and we've seen that through our various programs, that when you are empowering people on, you know, bringing in that aspect of the change in mental health literacy through the role that they play in the community becomes very powerful. Now, this is another extremely important element that we found out. When we started mental health literacy, we said that we would be giving knowledge to them. Well, typically, when we are giving knowledge, there is this whole assumption that it is a clean slate. But when it comes to mental health care, one of the earliest learnings we had was people would tell us that they seem to be having knowledge. So the word literacy perhaps doesn't really do justice to what we are all doing here in this space, because we are trying to bring in an attitudinal shift. There seems to be a belief that they already have knowledge. When we sit down with people and explain to them about mental health and aspects of that to various stakeholders, there's this whole discussion that, but then what happens to the notion that I have, the belief that I carry, or the knowledge that I seem to be using the word knowledge for what I have, and the decisions I'm basing on which I'm basing my decisions. What happens to them? So there is a whole effort of unlearning that has to happen. And we've been trying our best through the content that we've created at White Swan to help them unlearn and then accept and adopt a whole new paradigm around mental health care and their role in it. So there is this whole attitudinal shift and mindset shift, which becomes an extremely important objective under mental health literacy to that common man. The role of champions and influencers cannot be spoken less about, because mental health is a deeply personal subject, and you are bringing in attitudinal shift. Literacy, with all its traditional approach, certainly does a lot of good impact, but there is also this whole reassurance element that what has been given to you is right, and I can tell you. The influencers in the community must really partake in this whole effort of creating mental health literacy. And we've seen that over the last few years about how impactful it has been when influencers spoke the right language around mental health literacy. While we are on the subject of influencers, I really want to bring up the fact that some aspect of our effort on mental health literacy must be also on changing the attitudes and understanding of influencers themselves outside of the sphere also. Many a time, the way they will speak about mental health care damages the effort that champions like various organizations are doing under mental health care. So it really is important that we have the certain aspect of our literacy efforts being focused on influencers, so they understand that how do they really speak about it in the right manner, actually. We also understood that when it comes to influencers, in a community, if you go in, sometimes it really helps if you take an influencer first approach. When we started our work and we did some work in colleges, schools started approaching us and they said that, why don't you come and start imparting literacy to the school students. And we then started understanding the whole dynamics of the community called schools. And then we understood that the two most important influences of a student, which are parents and teachers, don't have the right perspective to mental health care. So if I don't begin really bringing in the change, attitudinal shifts, and the helping and enabling those influences to play the right role, it doesn't really help if I'm going to start educating the students. So we started designing programs for school teachers and some aspect of it to the parents also. So taking an influencer first approach into community would be a very good way, is what we had learned about mental health literacy in communities. This is again an important aspect of everything communication. It's extremely important to know our audiences. We did our mistakes in the early part of our work when we thought that we know what we need to take to people. But it is extremely important, and this is something that repeatedly came to us, that we need to go to the community without the aspect of mental health care sometimes to really understand what they are, what is that they will get influenced by, because we are at the end of the day trying to bring in mindset shift. So how are we going to do that? How are we going to accept them to accept that they have to unlearn? And which is about understanding our audiences very, very well and putting in that extra effort before we say that we have designed those programs for them. Which is also because information needs are unique. Like speakers before me had repeatedly mentioned that if one package would not fit everyone else, particularly because, as I've mentioned, that mental health or mental health aspect is a deeply personal subject. So when you are talking to me, it is extremely important that I'm convinced that you are really talking to me. So how are you contextualizing it? How are you customizing it? How are you really making sure that I have understood that you have really designed it for me as a person? So which is about repeating this whole thing many a times. Content and platform matter. Again, as I said, content is king, but it is about which platform we are delivering it. And we thought when we began our journey, we thought that if I put all our content in different languages on the internet, people will really be able to come there and consume the content, which continues to be the case. I mean, people come there and consume what they want. But we also realized that internet, for that matter, is accessible to an extremely small population, a part of the population. So how are we going to make sure that we take this content and then deliver it physically or in many other innovative ways to those people? So creating platforms becomes an extremely important element. We have the content, we know what we want to give them, we know what changes we want to bring in under mental health literacy, but how do I keep designing it for different platforms, because I am talking to different people, different communities. Any communication, any change that we're trying to bring in, a systemic change, requires us to repeat that a million times, different ways, keep saying it, keep saying those things, because there is this deep-seated notion which people believe is knowledge. I personally have understood that time has come where mental health literacy as a subject is not exclusive anymore. It is not owned by certain, by only those who are into mental health. It is time for us to partner with organizations and institutions which are outside of this space. Because like Dr. Srinath Reddy pointed out to us, that it is intersectional. We are increasingly seeing the effects of various changes that are happening in our society on their mental health, on people's mental health. So how are we therefore going to get mental health literacy becoming an integral part of economists, climate change activists, and for that matter, every other person? So I think as champions of mental health literacy, it is time for us to begin to partner with people who go beyond mental health care. And we've tried that in some way in many pockets, and they have been really successful. They've really created good results for us. One of the things that we did was to build a community engagement program where volunteers were trained on how they would conduct a one-hour conversation on mental health care in their spheres of influences. Volunteers picked up from every walk of life. It was an extremely effective public engagement program that we could create. Finally, I think we also need to look at models that people take and run with it. Like Tasneem was pointing out, that those collaterals that Tasneem's organization has created and are available free of cost for people to adopt and into their programs. We must make replicable models which people can see that it can be integrated into the scheme of things that they have. That really multiplies the effect disproportionately. And that is how perhaps we would look at bringing up systemic change into the vision that we have for mental health literacy. This is what we have had as a learning. Thank you so much for this opportunity. It's wonderful.
Thank you so much for that wonderful talk. I think, the idea about attitudinal shifts, going out into the community and actually learning from the community and understanding the context within which we serve the people is so important. And actually understanding who the influencers are, and actually how do we educate the influencers, because they're going to then talk to the other people, the children and everybody else. I've been given permission to run over a bit because I think it's quite important that we have some questions and answers from the esteemed panel. Just to take one of the questions. So it's an interesting question about resources. So we talk about mental health and we talk about supporting people with mental health problems, but if their challenge is the fact that they don't have any money or their finances are at risk, all the mental health support in the world may not help them, is what the challenge in the question is. especially post-COVID, when people have gone into poverty more, and we're going to see more mental health challenges. So I just wondered if the panel could think about that little bit, that sort of conundrum we're in, as we want to give people mental health support, but we can't actually solve their problem that's caused it. Professor Reddy, maybe you'd like to take that one from a public health perspective.
The question is whether we are talking about resources for the individuals and the families, or are we talking about resources for the government, which is supposed to be providing them support and coverage? If it is the former, which is basically related to the people who are afflicted or their families, that calls very clearly for ensuring that countries quickly adopt systems of universal health coverage, in which mental health is also covered very explicitly. And unless we actually have a very good system of universal health coverage, for which everybody must campaign who's interested in health, we will see many people being disadvantaged because they do not have the resources. You cannot depend only on philanthropy. Though philanthropy and charity help a little, it cannot be left to charity. It has to be the obligation of the society as a whole, represented by the government, in order to provide the resources. If we are saying what happens to under-resourced countries where governments themselves may not have much resources, certainly I believe if we can provide as much care as possible in primary health care, which is not resource intensive, there we will be able to still provide a lot of support and relief. But essentially, we ought to really aim for a primary healthcare led system of universal health coverage if we want to provide care to all the people who need it, rather than just an occasional person who might benefit either from governmental attention or from philanthropic charity.
Thank you very much. And yes, please, Dr. Nadkarni.
So I'll probably take the other part of it, which is around resources for the individuals and the effects it has on their mental health. I think historically the larger mental health space has focused on responding to mental illness downstream, without focusing too much on the upstream social determinants of mental health problems. And it's not possible, I think, to look at mental health, or for that matter, health in general, taking it out of the context within which a person lives. And one of the important things when it comes to context is economic resources, and then and the other side of it is poverty. And there's very, very strong connections between poverty leading to mental health and vice versa, for a range of reasons, and people getting caught into the vicious cycle: poverty, mental health, poverty. And we have not focused too much on putting together public health or social interventions which will break this cycle. There is some evidence coming in now, but we kind of early days about interventions such as cash transfers to people with mental health problems, unconditional cash transfers or conditional cash transfers. And the evidence from this is mixed. There are kind of effects on certain indicators of mental health, but they are not on other. This has been tested in adults as well as young individuals as well. So early days to kind of comment yet, but it's a promising route to go down in. But I think at the end of the day, there is no questioning the fact that unless we alleviate some of or reduce the effects of some of the social determinants of mental health, just focusing on treatment of people having mental health problems is not going to solve the big problem that we are trying to solve.
Thank you very much. And just very quickly from the other panelists, one very quick question. How important is it for medical professionals, mental health professionals, to seek some form of emotional support? And can stigma be reduced when health professionals become more open about their mental health distresses? So does it actually help people if we become more open ourselves?
Let me take that question. And I think stigma is as much there among medical professionals, as there is in the community. So I think the first thing is for us, to talk about mental health in the medical space. And I think COVID again has demonstrated how among healthcare professionals, there has been a huge amount of increase in psychological distress. so many aspects of it have been affected. So I think it's very, very important for mental health care for healthcare professionals to focus on mental health. If the only way we can reduce stigma is when that happens, and I think Manoj mentioned that very well, when you have influencers in the community talking about mental health. So I mean, I'm so glad that in this panel today we have Professor Srinath Reddy, who is not in that sense a mental health expert, really talking about mental health. And I think we need much more of this, so that we can make it topical, we can make people empowered to talk about it, reduce stigma, and accept care. And I think it's very important to recognize that a lot of mental health distress lies on a continuum. And if it is identified early, you can prevent progression to more severe forms of illness, to suicidality, and so on. So I think there is tremendous advantage in identifying and getting help early in one's problem.
Thank you very much. Yes, Dr. Nadkarni.
Sorry to be hogging the discussion, but
No,
it's amazing. I was speaking at a conference of Indian Psychiatric Society West Zone last week, and I had kind of answered a similar kind of a question. But at the risk of repeating myself, I just wanted to add to what Pratima said. I think the problem is with there's no doubt that health professionals should be speaking about their mental health, because they have been affected, especially in the current circumstances, by the things that are happening around them. But I think the problem lies in the way in which society has conditioned health professionals over the years across the world, where we as health professionals, especially doctors, are made to believe that they are not supposed to express their distress, and kind of are supposed to be superwomen and supermen, which we are not. But this conditioning basically means that health professionals will not speak about their distress, and that festers and that manifests in other ways. And I think it's time society allows health professionals to speak about the distress that they are experiencing without that reflecting on their abilities or competencies as health professionals. I think that's very, very important. That conditioning needs to go away, and to understand that at the end of the day, health professionals are also human beings who experience the same kind of distress that everyone else does.
Thank you very much. Dr. Manoj, would you like to carry on?
Thank you. From our learning, there's one more element into this whole aspect of mental health professionals and mental health. This whole community of health students, college students who are doing their healthcare degrees. We've had the opportunity to work with the Indian Medical Association to impart literacy to the students of various medical colleges across the country. We have understood that if we have to really bring in the changes that Dr. Pratima Murthy and Dr. Nadkarni pointed out among the healthcare professionals, we may have to begin in the colleges. We will have to take this whole literacy, and because it requires a generational change. There is one generation which really creates a tipping point for us to say that I am going to remove stigma. And we created a book for the healthcare students, and they loved it. They understood the need for it. And not just those who were going through this problem, but others in the college. And it is time for us to really make sure that systemic change is brought in at that level where we try to break this whole chain.
Thank you very much. And now to close the conversation, because Dr. Raja, I just wondered whether you would like to just say anything about this topic, this question, or just to close this for us with any final thoughts of yours.
Thank you, Dr. Lakhanpaul. So I actually wanted to go to the previous point of discussion and really say that experience on the ground, programs like the Nagpur program and others have shown that mental health really needs to be multidisciplinary, and without social interventions, really, it's difficult to make a dent, and things we grapple with all the time, issues of adherence, or even providing valid psychoeducation is very dependent on the circumstances of the individual, and just linking people to entitlements as a social intervention is important. So we need to really step out of being just pure healthcare providers and look at mental health as a multidisciplinary approach. And the second thing that I wanted to say that, with what everyone else has said, yes, healthcare workers' mental health is at least now being spoken about. And there are interventions in a country like India. There is recognition of, say, what the ASHA worker or the front line experienced during the pandemic, and it was hugely debilitating as people on the ground. And, with our ears very close to the community, we realized that ASHAs were really, really going through a very difficult situation. And I believe there are interventions being developed with experts like NIMHANS and in the digital space that can reach community health workers to begin with. Doctors, I guess, are a different ball game. So, but this was a very interesting panel. Thank you.
Thank you. We've had actually an amazing panel. It's like so many different disciplines, so many different thought-provoking topics. And it just shows that it's so important for us to come from all angles when we're discussing mental health. At this point, if you just stay with us for a couple of more minutes, we're going to actually bring in Professor Raghavan, but I will introduce him properly in a minute. But I had a poem that I had written over the last week around mental health, and it's a very rough poem, so please don't criticize it too much because it's a bit, but I just wanted to put that at the end of the session, really. So just bear with me for 1 minute. So it's really about mental health and the things that you were saying. They look at me as though I'm dead, yet I'm still here and alive. They pity me with words untold and can't look me in the eyes. You think because I don't come to work, I have lost my soul inside. You take me by the hand and say, "They there, we're all so kind." But no one really hears me, my voice that hides within. No one wishes to truly listen to the darkness deep inside. You make decisions for me, not asking me my thoughts. You wonder why I talk no more when you make me feel so small. You call it mental health. Please give it another name. I'm not mental. I'm just me, a person struggling with my life. So that, thank you very much for your participation in this wonderful conference. And on that note, I would like to invite our hosts for this conference. So Professor Raghavan has been leading us over the last few years for the MeHeLP project. And it's thanks to him that we're actually all on this platform today. So I'd like to give him a big thanks and welcome him to the floor. But I would also like to thank our co-investigator as well, Professor Asha Banu, who is Professor of School of Social Sciences at TIS as well. So thank you both, and please do close this wonderful conference that I've enjoyed every minute of, and it's over to you now. Thank you.
Thank you, Monica, for chairing an excellent panel session of great speakers and great movers and shakers in India. And I think very privileged to have you here. And I think it's a privilege of MeHeLP India to actually bring you all together into this space, really. And I think I'm very grateful to you for coming here. So I think for today's presentation, also for the last 2 days, we had excellent speakers from different walks, truly interdisciplinary, the way we actually talked about earlier on, a truly interdisciplinary dialogue and interaction, which is what we actually required. So, and I think we also had a kind of 3 days of Kerala conversations, specific to the Kerala context of how things need to be shaping up in Kerala. So what can I say? 3 days of fabulous, exciting, inspiring conversations on this space called MeHeLP India, which was not there for 3 years ago. And I think we have made this happen within a span of 3 years. And I think which is actually a great achievement for us to actually have this conversation together, collective conversation, really. So, it's over this last, I think, like 6 days or so, we really had a festival of fearless conversations around mental health and well-being and mental ill health and mental health literacy. And what we know as culturally appropriate mental health literacy is something that we wish to promote in relation to looking at the cultural heritage of India, looking at the cultural norms of India, the spirituality and religious concepts of India. All these things come together, as many of those speakers have actually said, in kind of social, economic, and other perspectives as well. So I think it is important that we think about that in a much broader context of things. So we have heard about the work of the MeHeLP team, both in the Kerala context and also in the pan-India context. And we also had speakers from the field of esteemed speakers from the field of mental health, arts, theatre, film actors, NGOs, filmmakers, public health officials, and many, many more. A truly interdisciplinary conversation. Many people told me a few months ago, we don't know what you mean. This is not possible. But I must not prepare to take no for a word. And I think, we have to, try. It happens. It has happened. This is evidence. What more evidence do you like to actually bring people together and talk about mental health and well-being in this context of the pandemic? So we had a tight program over the last 6 days or so on this virtual platform, which we had to learn very fast in terms of how things operate in this context, really, because we were planning to actually have a face-to-face conference earlier on, but that was not possible. So, and that has actually helped me to actually link up with all of you over the last few months in terms of bringing everybody together into the space to actually converse and share our ideas. And inspire many people in India and also outside India. So I feel this is a start. This is the start of a journey together in making the conversations around mental health and well-being and also culturally appropriate mental health literacy in urban, rural, and tribal India. It's very much applicable to many other countries too, but I think in this context, this is actually in the Indian context that we're actually talking about that. As Professor Reddy he mentioned, this is calls for a public mental health initiatives in India and how some of those ideas could be transformed into actions and practices and developments and knowledge sharing and many range of activities, really. So, and I think it is in this context that the mental health literacies, as we call, mental health literacy is not a unified concept, as proposed by Joe. We believe this is a mental health literacies concept because there are many things actually coming to this. Just following the Western medical model alone is not a mental health literacy. And I think we think there are many other dimensions that actually add to this process. So I think it shows us how we need to work together, how we need to collectively think and act and shape policy that to make life a reality, to make life an affordable and enjoyable concept for people within urban and rural context, really. So this is crucial in the Indian India context, as it is actually going to be it is one of the leading economies in the first three in the next few years. So we discussed a diversity of approaches. There is no one pathway here. There is no one shirt or number. There is no one size fits all. So the diversity of the approaches here. And that is the truly richness of how we need to actually engage in this discussion. Because there are many ways of how things are actually acting. The examples of Manoj and examples of Tasneem and many of the people and examples of Sangat, examples from NIMHANS and the public health body, and many other people are actually being here in this stage and talks about their own work. And I think there are diversity of approaches and all of it has its own merits. And I think together that brings that strength, power, and magic to our conversations in promoting culturally appropriate mental health literacy in India. So it is, so watch this space is what I say. Watch this space as to where we are moving further. I know the project is actually coming to a close, but the work is not going to come to a close. We have started the work. And I think that is the way I would look at it. We have many more opportunities to bring people together in the next 5, 10, 15 years. I visualized a kind of 20-year plan as to how we look at mental health literacy programs in India. So it is important that together we talk together, and together they can transform and change the practices in the Indian context. I wish to thank the MeHeLP team for believing in me, that tough guy and nothing takes nothing, believing in me that this will happen, and especially for the MeHeLP research team in India, Professor Asha, Meena, Sanjana, Archer, Anaga, Sindhu, and Parvati for all those conversations. And whenever I said that this is going to happen, believing in me and also working hard for making all those things to actually happen. So truly collective teamwork, and I think it's very important that we do that. I also wish to thank our theatre and film partners in making a start in our conversation. There are a lot of resources that we have actually built over the last 3 years, reusable learning resources, which is applicable to many organizations in India. Theatre pieces, films, and many other kind of digital stories, and all those things are actually reusable learning resources that people can actually make use of in teaching and promoting mental health literacy. I also wish to thank my UK partners in making all these things possible. And a lot of hard work has actually gone into organizing this conference, this virtual conference, which I had to learn within a period of actually a week or so. So special thanks to the research fellows and research team in India, and thanks to Parvati and Krishnesh, our digital consultant and IT advisor, in making all those things possible in a short span of time. I also wish to thank our NGO partners, Dr. Chandran and Dr. Manoj Kumar from MeHeLP and MHAT services in Kerala for all the connections and all the work that they've actually done in promoting our project in Kerala. So I think I keep on saying that kind of wording is about Albert Einstein. Imagination is more important than knowledge. Knowledge is limited. Imagination encircles the world. And I think that is very true here. But I think there is also another way of actually looking at it. The Scott Fitzgerald, the American novelist, once said, the test of first-rate intelligence is the ability to hold two opposed ideas in mind and retain the ability to function. And he also said that one should be able to see that things are hopeless and yet be determined to make them otherwise. And I think it is in that context that I pitch the MeHeLP team and the MeHeLP project in relation to how we go further in expanding that knowledge to urban, rural, and tribal India, and many other countries that we may actually work with in the future too. And a final word from the inspirational of quotes from a person whom I admire most, who have actually influenced most of my life so far, Swami Vivekananda. And he actually said, one of his great words is that, arise, awake, and stop not till the goal is actually reached. And I think we have just started the journey now. Let's walk together, let's talk together, and let's make it happen. Thank you very much, and I'm very blessed to be here, and thank you for all your help and support. Over to you, Asha.
Yeah, after 6 days of deliberation and also listening to this panel, it's so interesting to see that there is recognition for social models. And when Dr. Nadkarni spoke about upstream determinants and public mental health, it's a good beginning. It's very important to focus on social models. And like over the 6 days, we've seen several models, be it Kerala, be it the other parts of the country, several models. And with so many models, and why there is still insufficiency in the mental health care world is important to deliberate on, because there is no scarcity of models. There are diverse strategies, perspectives across North, East, South, and West. But then why there is such kind of insufficiency whenever we speak about mental health interventions, etc. It's a point for us to focus on. And like Raghu has called everyone, thanked everyone. I would also want to talk about the fearless participants of this study, their stories. Their stories got converted into digital stories and short films. And the stories have shared about opportunity costs, the financial implications, the challenges they face, the stigma and the discrimination. And their voices will definitely go a long way in terms of building advocacy strategies. And they are so powerful. They are from rural or urban, or even from the a tribal context. There are fearless voices. They have really articulated what they have lacked. So this is truly a bottom-up approach. We have built the voices from the community, And that also talks about what is the insufficiency in their lives, the opportunity cost in their lives. So thanking all the participants, thanking all the field partners. Now, the one aspect, I'm borrowing one of our research assistant, I think Uma, she shared this, that our project is the most resilient project because the project started in 2018. We faced Nipah in Kerala, and there was Kerala floods in 2018. And again, we had this COVID pandemic. Irrespective of all of these challenges, the team had been really resilient thanks to Professor Raghu. Now, I want to say maybe Raghu equates to resilience because when all of us wanted to give up and also wondered how we are going to continue in the field, how are we going to collect stories, how are we going to make theaters, Raghu stood there and steered all of us towards the right direction. And today when we see, like, all of us thought that okay, we are working in bits and pieces, but in this conference when we are looking at it as a wholesome piece, it's a lot of work. And thank you, Raghu, for leading us. And this is really an emotional moment for all the team. And recalling, the efforts of the research, I mean, they require a special mention because irrespective of the challenges, they were in the field and they continued, they persisted till the deliverables are accomplished. So I think Sanjana, Archa, Anaga, Sindhu, Uma, Ardra, all of you require a special mention. And to the team partners, Mehik and MHAT, and all the resource persons who joined us in this event. Thank you so much. And definitely there is a long way to go. Hand in hand, we have to go. And then there should be sufficiency and there should be efficiency in all the models of mental health intervention. That's what we are aspiring for. Thank you so much.